Good morning. This hearing will come to order. I want to first of all thank all the witnesses for taking the time to appear, for taking the time to prepare your testimony, and look forward to your oral testimony and your answers to our questions. On its surface, people may be scratching their heads going, what is the Committee on Homeland Security and Government Affairs holding a hearing on potential Medicaid or other government federal funding of opioid crisis? Why are you doing that in this committee? We actually have a pretty long history of delving into this particular epidemic, this particular healthcare crisis. My own involvement started with reports at the Toma VA healthcare facility where there was overprescription, mixed toxicity of drugs resulting in the death of a young Marine because of drug toxicity, and finding that within that investigation we had about a 350-page report, 5,000 pages of supporting documents, but we also noticed drug diversion potential within that investigation. This committee has held 3 field hearings in Wisconsin, a field hearing in Ohio, 1 in New Hampshire, 1 in Arizona. I proposed the PROP Act, prescribing responsible opioid prescriptions or promoting responsible opioid prescriptions, which CMS actually viewed as so important that they implemented without us having passed the law, which was kind of nice. Senator Portman has been very active on this front, coming from Ohio, one of the states really stricken by this epidemic, instrumental in passage CARA, proposing the STOP Act. Both Senator Portman and myself, Senator Hassan, were at the White House last week for the signing of the Interdict Act, which funded and authorized detection devices for fentanyl, which is becoming more and more of a problem. And of course, my ranking member, I appreciate Senator Peters filling in, but Senator McCaskill has been very aggressively pursuing the marketing through pharmaceutical companies and seeing how we can solve the problem from that aspect. So this committee has been very highly involved in this, and I just want to kind of lay out specifically why I got involved in this particular issue. And it started with a pretty interesting, pretty depressing article written in Commentary Magazine by Nick Eberstadt, a demographer, works for American Enterprise Institute. And in that article, he was quoting Alan Krieger, the former chairman of President Obama's Council of Economic Analysis. And Mr. Krieger published a report talking about prime age working male labor force dropouts. He said nearly half of all prime age working age male labor force dropouts, an army now totaling roughly 7 million men, currently take pain medication on a daily basis. Went on to quote the author of Dreamland, Sam Kionis. This resonated with me, having been a former employer. I realize an awful lot of people, one of the primary motivating factors for getting a job is to get health care. And when you combine government programs that provide free health care, and then on top of that, a government program that provides you a prescription card that allows you access to products at a very low price that you can sell, divert into illegal drug trafficking markets and supplement your income to the tune of thousands of dollars per year. Unfortunately, some people take advantage of that. Mr. Kionis is quoted in that article out of his book, Dreamland. I just want to read the quote. Now, he's actually in Portsmouth, Ohio, when he's talking about this, that the Medicaid card pays for medicine, whatever pills the doctor deems that the insured patient needs. Among those who receive Medicaid cards are people on state welfare or on federal disability program known as SSI. If you could get a prescription from a willing doctor, and Portsmouth had plenty of them, Medicaid health insurance card paid for that prescription every month. For a $3 Medicaid copay, therefore, addicts got pills priced at thousands of dollars with the difference paid for by the U.S. and state taxpayer. A user could turn around and sell those pills obtained for that $3 copay for as much as $10,000 on the street. Later on, Nick Eberstadt just writes, disability checks and means-tested benefits cannot support a lavish lifestyle, but they can offer a permanent alternative to paid employment, and for growing numbers of American men, they do. Now again, that article piqued my interest. And so I asked my staff, I said, okay, this is kind of being laid out there, not necessarily as a theory, but anecdotally, showing a real problem. And so I asked my staff, can you take a look, do a data search and find out and just identify individuals that have been either convicted or at least charged with taking their Medicaid card, using obtaining those pills and then selling those in the open market in 4 days. They identified 261 defendants that had either been charged or convicted of doing just that. Okay, we've got a problem that needs to be further explored, and so we did explore it. And today we're issuing a report based on our further study in which, again, staff has uncovered about over 1,000 defendants that have either been charged or convicted of using their Medicaid cards and diverting in some way, shape, or form. Along the road, even though we're focusing on Medicaid, we have about 243 defendants that diverted Medicare funds. There are currently 60 active criminal investigations of opioid diversion through the VA healthcare system. So again, this is a government program-wide phenomenon where American taxpayers are providing well-intentioned funds into some of these programs, and those funds are being utilized to divert drugs, sell in the open market, and in some cases fuel some pretty interesting criminal enterprises or just support a lifestyle of non-work, which is not healthy. I have, as a follow-up today, issued a letter to the Acting Secretary of Health and Human Services asking what controls, what can we do, to what extent are they tracking this, to what extent are they aware of how much money we spend on Medicaid, Medicare that's being used in this case. Now, I do want to point out what I'm not saying either in this report or in this hearing. I'm not making the claim that this is just because of Medicaid expansion. Obviously there's more dollars available through Medicaid expansion. There's maybe some indications. HHS had a study that we had to extract from them showing that there may be a difference between Medicaid expansion states versus non-expansion states. But this crisis, this epidemic began way before Medicaid expansion. I'm not saying that Medicaid doesn't help an awful lot of people, and the dollars used for treatment haven't helped untold numbers of people. I'm not saying this is a primary cause. I think what we are certainly saying is this is an unintended consequence. It's certainly a contributing factor. It maybe enables something that maybe shouldn't be enabled, and it's a very serious problem that has to be taken a look at. And again, coming from a problem-solving process, I think it's kind of hard to deny when you take a look at this report, take a look at some of these examples, and we have 110 of some of the most egregious examples in here involving drug rings, grocery stores are being used as kind of central ports, pharmacists, nursing homes. I mean, again, it's almost hard to understand the complexity of some of these schemes. A podiatrist actually injecting chemicals to create pain so we can get more opioids and be able to divert those for profit. So the schemes are actually really beyond your imagination, but people use their imagination. So it's kind of hard to deny when you take a look at these examples, this isn't a problem that needs to be further explored. And I'm just saying that we ignore this aspect, and it's just an aspect of this overall epidemic. We ignore that aspect, this particular phenomenon, this reality at our own peril. So again, I want to thank the witnesses. Look forward to your testimony. I'll turn it over to my substitute ranking member, Senator Peters, for his opening comments.
Thank you, Mr. Chairman. Today, as mentioned, I'm filling in for Ranking Member McCaskill, who wanted to be here, but due to extenuating circumstances, cannot be here. But I would like to ask for unanimous consent to include her opening statement and a memorandum prepared by the committee's Democratic staff into the hearing record today.
Without objection.
Thank you, Mr. Chairman. And I would also, before I begin my statement, also like to welcome our new colleague to the committee, Senator Doug Jones. Welcome to this committee. Congratulations on your election. You're going to find this a very interesting and committee, one with doing very important work, and we know you're going to do an outstanding job. Thank you for joining us.
While you've said that, I wanted to wait until Senator Jones actually showed up. I also want to welcome this committee. I think you'll find, hopefully in the hearing today, we don't do show trials here. This is really a very bipartisan committee. We conduct ourselves with that level of decorum, and it's really about uncovering the truth, laying out realities so you can solve problems. So, again, I want to congratulate you on your election. I was really pleased when we spoke earlier. I'm really pleased that you joined our committee. I think you will enjoy your time here as well. But
thank you.
Sorry for interrupting.
No, that's good. Thank you. At the start, I think before we start this hearing and hear the testimony from the folks before us, I think it's important to reiterate that Medicaid expansion has produced not only historic coverage gains, but it also has very far-reaching positive health effects for American families. At its core, Medicaid and the ACA's Medicaid expansion are critical programs that help hardworking American families enroll in health care coverage and protect our nation's vulnerable. Nearly 80% of Medicaid enrollees come from a working family, and over 40% of Medicaid enrollees are children. Medicaid is a program that literally saves lives. I think we can all agree that when you or your family member or friend gets sick or hurt, should be able to access affordable health care coverage. Medicaid and Medicaid expansion serves as a bridge to affordable health care for millions of working families in our country. And I'm sure we've all heard stories, but just as a reminder, these programs are there to make sure that someone's parent can have that needed surgery, or a child's family can afford the high cost of their cancer treatment, or that a person who has been injured can get care that they need to get back to work. Medicaid has also been critical in fighting the opioid epidemic. Opioid abuse and its tragic impact continues to be a growing problem in my home state of Michigan, as it is around the nation. Between 2014 and 2015, the Centers for Disease Control report that drug overdose deaths in Michigan increased by over 13%. In 2015, more than 2 million people across the nation struggled with prescription pain reliever substance abuse disorder, an unfortunate number that continues to trend upward. As we work to combat this very serious epidemic, the Affordable Care Act has greatly expanded access to treatment in Michigan and across the nation, including for individuals with substance abuse disorders. Prior to the passage of the ACA, many individuals with substance abuse disorders were unable to get the care that they needed. Since the passage of the Affordable Care Act, the uninsured rate in Michigan has been cut in half, and more than 600,000 individuals are now enrolled in our state's Healthy Michigan Expanded Medicaid program. Combined with the private exchanges in our state, nearly 900,000 individuals in Michigan have coverage through the Affordable Care Act. Many of these individuals are now able to access health care insurance for the very first time in their lives. Since the ACA's Medicaid expansion went into effect, more than 1.6 million Americans have gained access to this vital treatment. Last year, this committee, the Homeland Security and Government Affairs Committee, but the subcommittee that I'm a member of, which is the Permanent Subcommittee on Investigations, had a hearing on the opioid epidemic, and we heard from witnesses who, like each of you here today, are fighting on the front lines. I spoke with Dr. Thomas Gilson, a medical examiner from Cuyahoga County, who told me how Medicaid expansion is literally helping them save lives by giving people suffering from addiction into treatment programs. I also spoke with Thomas Sinan, Jr., Chief of Police for Newton, Ohio, and he largely agreed with Dr. Wilson and went on to tell me, and I'm going to quote him here, to reduce demand and in turn reduce supply, we have to get people into treatment, and one of the programs our teams are doing out there in Hamlin County area is signing people up for Medicaid to try to get them into that treatment. Their overwhelming message to me was that we must preserve Medicaid and work to improve the critical health services that the program offers, because it is literally saving people's lives each and every day. And so today, I appreciate each of you for being here today, and I look forward to hearing about how we can work to improve our nation's Medicaid program to better serve the families enrolled and to continue our efforts to combat the abuse. And I have no doubt that there are improvements that can be made, and we're going to hear about some of those improvements today. And I look forward to your suggestions. But I want to end by stressing we must do it in a way, as we make these improvements, we must do it in a way that does not jeopardize the health care for those who so desperately need it. Thank you.
Thanks, Senator Peters. I'd also ask consent that my prepared opening remarks be entered in the record without objection. And as we're welcoming Senator Jones, we also have to say goodbye to Senator Tester, who's been a very valued member of this committee. So we hate to see him leave, but we're happy to have Senator Jones. I do need to announce change in subcommittee membership as a result to make it official. So Senator Hassan will replace Senator Tester on the Permanent Subcommittee on Investigations, and Senator Jones will replace Senator Hassan on the Subcommittee on Federal Spending Oversight and Emergency Management. So that makes it all official. Now, it is the tradition of this committee to swear in witnesses, so if you'll all stand and raise your right hand. Do you swear that the testimony you will give before this committee will be the truth, the whole truth, and nothing but the truth, so help you God? Please be seated. Our first witness is Mr. Sam, is it Adolphson or Adolphson?
Adolphson.
Adolphson. Mr. Adolphson is Vice President at Rockwood Solutions and a Senior Fellow at the Foundation for Government Accountability. Mr. Adolphson previously served as the Chief Operating Officer at the Maine Department of Health and Human Services. He also served as Maine's Deputy Commissioner of Finance with oversight over the state's Medicaid budget. Mr. Adolphson.
Chairman Johnson, members of the committee, thank you for the privilege of testifying. For 3 years, starting in 2014, I sat in my office in Maine and I watched something terrible unfold right in front of me. I'd review Medicaid pharmacy spending in one meeting, and then I'd walk down the hall for my next meeting about the opioid crisis and how to stop it. And the only thing increasing as fast as the budget line for opioids was the body count from overdose deaths. In the morning, I'd read a newspaper account of someone caught up in a drug arrest, and that afternoon, I'd see that same person again when reviewing welfare enrollment data. It happened far too often. Our welfare fraud team worked daily with drug enforcement agencies to investigate when Medicaid members sold their pills or Suboxone strips or traded their welfare cards for heroin. I worked with the Medicaid fraud control unit as we reviewed cases of caregivers diverting pain pills from desperate and dying Medicaid patients. I wish these were isolated incidents, but they aren't. The paths of dependency on Medicaid and addiction to opioids are often intertwined. At the same time, I was helping to run a Medicaid program that was funding record-breaking amounts of opioids. The nation was being told that the solution to the drug problem was to put more people on Medicaid. Medicaid expansion was held up as a silver bullet solution to the drug crisis. But no one was considering the dangerous side effects of Medicaid. Now, the danger of prescription opioids is now better understood. They are the gateway to addiction. 4 out of 5 heroin users started by abusing prescription drugs. When that free plastic Medicaid card is issued, it doesn't only pay for drug treatment. It also supplies opioids at a staggering rate. The numbers are alarming. 1/4 of Medicaid members get an opioid prescription, and the highest rate is among the Medicaid expansion population of able-bodied adults. A CDC study done by the Obama administration showed that someone on Medicaid was 6 times more likely to die from an opioid overdose. While 1 out of every 5 people is on Medicaid, the program pays for 2 out of every 5 emergency room trips for opioid and heroin poisonings. Medicaid expansion has not fixed this problem, but it might have made the problem worse. Rhode Island increased their Medicaid enrollment by 66%, and their overdose deaths doubled. West Virginia, Ohio, Pennsylvania all expanded Medicaid, adding a total of 1.5 million adults to the program. They rank first, second, and third, respectively, in the number of drug overdose deaths. Of the 10 states with the highest rate of opioid deaths, 9 have expanded Medicaid under Obamacare. This correlation is very concerning, and the question of causation begs for more inquiry. As millions of adults have been added to the program, prescription drug abuse has multiplied. With no out-of-pocket costs and few restrictions on providers, prescription painkillers have flowed unfettered to Medicaid recipients. And this injected a whole new supply of free opioids into the market. I also witnessed people on Medicaid withdrawn from the community, not working, living an isolated and idle life that's more prone to drug abuse and addiction. 52% of able-bodied adults on Medicaid, half, don't work. And this is really tragic because we know that for so many, work is the best answer to move away from a life of crime or addiction. Rather than expanding a broken program that funds pain pills, we should focus on breaking the cycle of pain and dependency by helping people get back to work. This drug problem is bad enough. We have to make sure that Medicaid isn't throwing fuel on the fire. We need to make sure that Medicaid isn't funding the drug problem, but instead is structured to promote work and health for our neighbors. Thank you.
Thank you, Mr. Adelson. Our next witness is Mr. Otto Schalk. Mr. Schalk is a prosecuting attorney for Harrison County, Indiana. In addition, Mr. Schalk produced the film A Hit of Hell, a documentary about the opioid epidemic. Mr. Schalk.
Thank you. Good morning. My name is Otto Schalk, and I'm the prosecuting attorney for Harrison County, Indiana. We are a community in southern Indiana that in many ways is representative of much of our nation. I'm honored to serve my county and my state as a prosecutor, and I'm humbled to be before you this morning. I embrace this opportunity to share with many of you what us in law enforcement see and deal with on a daily basis. Every time a hardworking American pays their taxes, they are inadvertently funding drug dealers with a new supply of high-powered opioids that are poisoning our schools and our streets. That's a bold claim. However, as a prosecutor, it's something that I see routinely. It's no secret that our Medicaid program is ripe for fraudulent activity. Prosecutors know this, doctors know this, and the reality is that drug dealers know this as well. An individual need not only traffic illegal street drugs to qualify as a drug dealer. A Medicaid beneficiary that is selling their prescription pills is no different in the eyes of the law. It bears mentioning that those who are impoverished are far more susceptible to end up in the criminal justice system. Anyone who has spent a day in a criminal courtroom across America knows this to be true. In my role as prosecuting attorney, I have prosecuted at an extreme disproportionate rate those that are Medicaid recipients. I see the disparity each and every time I walk into court. For a reference point, just looking at our reported data from our county, from clients that are on probation that are in an alcohol and drug rehabilitation program, more than half of them are making less than $10,000 per year. In the simplest of terms, whether it is labeled as Medicaid fraud or drug dealing, it exists for the same reason that bank robberies occur. There's a pile of cash, and those with ill intentions will let greed lead them to commit crimes. Now, common sense dictates that when we give someone making less than $10,000 per year, that's struggling to keep the lights on, that's struggling to put food in the refrigerator, and we give them a 90-count bottle of hydrocodone each and every month, and some of these pills are going for $15 a piece on the street, tax-free, that they're going to see the opportunity for financial gain. If we believe otherwise, we are naive. Unlike other street drugs such as heroin or meth, a dealer in opioids doesn't need to have someone that's well connected in the drug culture to funnel their supply. A dealer in opioids simply needs to know a willing doctor and claim to have an ailment. And if the opioid dealer is on Medicaid, they receive their supply of high-powered narcotics for free or nearly free. Simply polling our jail and our probation officers, I found that most of our inmates and probation clients that are on probation for drug-related charges are taking, pursuant to a valid prescription, 2 to 4 high-powered opioids each and every day. That's 60 to 120 pills that are being prescribed each month. Now, conservatively, some of these pills are going for $30 a piece on the street. The incentive to opt off Medicaid to better one's lot in life is drastically reduced for individuals that are making $3,600 a month tax-free and selling their prescription pills that they are getting at no cost. To that extent, the abuse that we are seeing among Medicaid recipients as it relates to misuse and or selling their prescriptions is rampant. And that's just based on what we are seeing and what we are filing. And those of us in law enforcement know that we are only catching a very small percentage of those committing these crimes. A reactive justice system coupled with a shortage of resources often leads to a small percentage of the bad actors being caught. A true number of those that are abusing the system would likely be staggering. Now, to be clear, I'm not here this morning saying that Medicaid isn't a tremendous asset for our nation, but I'm speaking from my own personal experiences as a prosecutor in the trenches. I see firsthand what is devastating our communities. I see day in and day out individuals that are Medicaid recipients dealing and abusing their prescription pills that are government funded. It's simply a fact. I see individuals getting arrested for selling their prescriptions, and yet they test clean for them when they're drug tested during the jail booking process. So is the opioid epidemic an unintended consequence of Medicaid? Certainly, with the increased amount of the impoverished having access to medical care, there is a greater likelihood that those who are impoverished are going to see the opportunity for turning a profit, albeit illegal, on the street. Now, one obvious solution would be to create a more rigorous checks and balances of the medical bills being submitted through Medicaid for payment. Are the prescriptions necessary? Is the opiate prescription in line with the treatment plan? I've never understood why so many of the people that I'm prosecuting are getting prescription after prescription of high-powered opioids when a simple over-the-counter drug could be just as effective. The opioid epidemic has brought devastation to our schools and our community. The opioid epidemic is far too complex to narrow its causation to one specific issue. And while the issues are complex and many, there is one recurring theme, and that's poverty. Until we take affirmative steps to create jobs, grow businesses, and slowly diminish the gap between the impoverished and the middle class, any changes that are made will be a Band-Aid fix to the underlying problem. I want to sincerely thank each of you for the opportunity to be part of this solution of this gripping epidemic. I look forward to answering any questions that you may have.
Thank you, Mr. Schalk. Our next witness is Mr. Emmanuel Tyndall, or Tyndall? What is it?
Tyndall, Mr.
Tyndall.
Chairman.
Mr. Tyndall is the Inspector General for the state of Tennessee. Prior to becoming Inspector General, Mr. Tyndall served with the Criminal Investigation Division as a special agent for 10 years, investigating TennCare cases, which is Tennessee's Medicaid. He has approximately 35 years of law enforcement experience and holds master's degrees in health and human performance, management, and criminal justice administration. Mr. Tyndall.
Thank you, Mr. Chairman, and committee members. As Mr. Chairman said, I'm Manny Tyndall. I'm the Inspector General for the Office of Inspector General in Tennessee. In 2004, the Office of Inspector General was created specifically to root out fraud and abuse in the TennCare program and criminally prosecute applicants and recipients who game the system. And as the Chairman alluded to, TennCare is simply our name for the Medicaid program in the state of Tennessee. The Office of Inspector General receives and triages more than 4,000 complaints each year. I think you will find that Tennessee is one of the few, if not the only state, that criminally prosecutes Medicaid applicants and recipients who engage in drug-seeking behavior or prescription drug diversion at the cost of the TennCare program. Our research indicates that states bordering Tennessee address recipient fraud administratively. I believe that suggests that Medicaid fraud is probably underreported nationwide. What I would like to share with you today is some examples of how the TennCare program is defrauded and how prescription drugs are paid for by TennCare that are diverted for illegal use. Approximately 80% of all arrests, 2,400 of our arrests were prescription drug diversion or doctor shopping related. The ages range between 21 and 78. 1,678 arrests were for drug diversion, which includes sale and forgery. The courts have ordered approximately $315,000 in restitution to be repaid to the Bureau of TennCare for these offenses. 709 arrests were for doctor shopping. Our doctor shopping law became effective June 18, 2007. Since that date, the courts have ordered approximately $292,000 in restitution to be repaid to the Bureau of TennCare for those offenses. Some of the schemes I've been witness to include recipients receiving valid prescriptions for prescription drugs, having it filled and paid for by TennCare, and then selling a portion of that medication on the street. Recipients are calling in prescriptions to pharmacies pretending to be employees of a medical practice and having TennCare pay for that medication. Recipients are passing forged and altered prescriptions written by other parties and then passing those prescriptions at pharmacies and having TennCare pay for that medication. Recipients are adding medication to a prescription being hand-carried between the doctor's office and the pharmacy and having TennCare pay for that medication. For example, if they may receive a prescription for amoxicillin, and between the doctor's office and the pharmacy, they'll add hydrocodone to that prescription and have TennCare pay for that medication. Doctor shopping. Doctor shopping is where a recipient fails to advise a provider that within the last 30 days, they have already received the same or similar narcotic medication that is being prescribed. There are usually multiple counts of this offense. Nurses and medical technicians are selling prescriptions already signed by the doctor. Some of those prescriptions are sold for as much as $80. We work very closely with our drug task forces who make the buys. Normally 1, 2, or 3 pills are purchased each time during a drug transaction, and usually 3 buys are made before we seek an indictment. Depending on the type of medication and drug and the milligram, the prescription medication can sell for $5 to $10 per pill, or some medications as much as $1 per milligram. With there being little or no cost overhead to the Medicaid recipient, if they were to sell an entire prescription of 90 hydrocodone 5 milligram tablets for $5 per pill, they would make approximately $450. If they did this every month, it would garner approximately $5,400 a year, and that's a very conservative estimate. That is for one person for 1 year, and we make approximately 140 or more arrests each year. I'm confident that many instances of TennCare fraud are not identified. Excuse me. The following cases demonstrate the lengths some people will go to obtain pain medication. A husband and wife would take turns intentionally burning themselves on their lower legs with boiling water and go to a different emergency room to obtain pain medication and have TennCare pay for the ER visit and the medication. We have charged 4 individuals for a 4th offense of doctor shopping. We have charged 1 individual with 25 counts of prescription drug fraud where she forged or altered prescriptions in order to obtain hydrocodone and oxycodone and used her TennCare benefits to pay for the medication. She admitting to selling the pills to support her lifestyle. I personally worked a case where I charged a young woman with 87 counts of obtaining a controlled substance by fraud and TennCare fraud and identity theft. She was the office manager at a doctor's office and would steal several prescriptions from prescription slips from a prescription pad each week. She would forge the doctor's signature and DA number on prescriptions in her name, her husband's name, many of her friends, and even her grandmother's name. Some prescriptions were paid for by TennCare, and some she would trade for half of the medication that person received. Mr. Chairman, thank you for the opportunity to speak, and I'm willing to answer any questions the committee might have.
Thank you, Mr. Tyndall. Our next witness is Dr. David Hyman. Dr. Hyman is a physician and a professor of law at the Georgetown University Law Center. Dr. Hyman focuses his scholarship on the regulation and financing of healthcare. Dr. Hyman.
Thank you, Mr. Chairman and members of the committee. Much of my testimony is drawn from a book that's going to be coming out in April, co-authored with Professor Charles Silver on the American healthcare system. The book is titled Overcharged: Why Americans Pay Too Much for Healthcare. And it explains how the ways in which we've decided to pay for healthcare services have predictable consequences on the cost and quality of those services, as well as the rates of waste, fraud, and abuse. Our public programs are particularly vulnerable to the latter set of problems. Today, we're here to focus on the opioid epidemic. I commend the committee for holding this hearing. Although a lot of what we've heard so far has been about the death rate, it's also important to note the opioid crisis has consequences in terms of destroyed lives, broken families and marriages, medical expenses, and lost productivity. My testimony flags 4 distinct issues: the seriousness of the problem, the complexity of the causes, the ways in which the design of our public programs make them particularly vulnerable to the sorts of abuse and overuse of the sort that you've already heard about, and the role that patients have played in this particular problem. In the interest of time, I'm going to focus on the latter 2 issues. In terms of the role of the causes, it's important to note that these are prescription opioids, and apart from outright theft, you need a prescription from a physician in order to get them. There's a serious problem with overprescription. The causes of that are somewhat complex, but there's certainly bad actor physicians out there who are willing to meet their patients in coffee shops and restaurants, write them prescriptions in exchange for cash. The book talks about one, Dr. Lee E., who was responsible for essentially a mini epidemic of opioid usage. There are particular parts of the country that have these problems. South Florida had so many pain clinics that the state earned the nickname Oxy Express. And so that, again, is an indication of the nature of the reimbursement system that enables these situations to develop. Now, both Medicare and Medicaid were designed to mimic Blue Cross and Blue Shield programs circa 1965. That is indemnity-based insurance, where the amount that was paid was tightly controlled, but the volume of services was really not controlled. If a physician said you needed something, the insurance paid for it. There wasn't much in the way of networks or pre-approvals or utilization review. Over time, the private market has evolved, but the public payers have remained largely passive bill payers. The results, as we observe in our book, are easy to observe with prescription drug fraud. Quote, "The government has studied prescription drug fraud in public programs repeatedly, and each time it has concluded that fraud is rampant." A 2009 GAO report on the Medicaid programs in 5 large states opened with the observation that investigators found tens of thousands of Medicaid beneficiaries and providers involved in potentially fraudulent purchases of controlled substances, abusive purchases of controlled substances, or both. 65,000 beneficiaries had engaged in doctor shopping. 400 individuals had gotten prescriptions from controlled substances from between 21 to 112 medical practitioners and visited up to 46 different pharmacies to get them filled. As long as you have a prescription, it'll be filled and the public payers will pay for it. Now, we've taken various steps to try and address these problems, including surveillance, prior approval limitations on the number of pills that can be dispensed, disclosure of information to physicians about the risks of overprescription, and prescription drug monitoring databases. Each of these reforms has the potential to help reduce inappropriate prescribing, but design details make a big difference, as does implementation. And the fact they are necessary shows how the design features of Medicare and Medicaid make them vulnerable to waste, fraud, and abuse. Last, the role of patients. The tendency is to focus on providers, but patients are often involved in prescription drug fraud. A 2011 GAO report involving Medicare found that doctor shopping was widespread, with more than 170,000 Medicare beneficiaries receiving prescriptions for controlled substances from 5 or more medical practitioners. Another study found that 500,000 Medicare beneficiaries were prescribed excessive amounts of opioids, including 22,000 who appeared to be doctor shopping. So the problem is not limited to Medicaid, it's not limited to public programs, but the design features of the public programs make them more vulnerable. Thank you very much.
Thank you, Dr. Hyman. Our final witness is Dr. Andrew Kolodny. Dr. Kolodny is a physician and the co-director of opioid policy research at the Heller School for Social Policy and Management at Brandeis University. He previously served as chief medical officer for Phoenix House and as chair of psychiatry at
Maimonides.
Thank you, Medical Center in New York. Dr. Kolodny.
Thank you for the opportunity to appear before you today. I'd like to also thank Ranking Member McCaskill and members of the committee for this opportunity. The opioid crisis is an epidemic of opioid addiction, meaning that the reason the U.S. is experiencing record high levels of opioid overdoses, the reason we're seeing a soaring increase in infants born opioid-dependent, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems has been a sharp increase in the number of Americans suffering from opioid addiction. The primary driver of the opioid addiction epidemic has been made clear by the CDC. This slide is a CDC graph. It shows that as opioid prescribing began to soar in the 1990s, it led to parallel increases in opioid addiction and overdose deaths. This is an epidemic caused by the medical community overprescribing opioids. On this graph, the green line represents opioid prescribing, the red line represents opioid deaths, and the blue line represents opioid addiction. As the green line went up, as opioid prescriptions began to soar, it led to parallel increases in addiction and overdose deaths. The reason the green line began rising, the reason the medical community began prescribing so aggressively is because we, doctors, were responding to a brilliant, multifaceted marketing campaign that changed the culture of opioid prescribing. Starting in the 1990s, we began hearing that patients were suffering because we were too stingy with opioids. We began hearing that we should stop worrying about getting patients addicted. We began hearing that even with long-term use, the risk that a patient would get addicted was much less than 1%. We would have been less gullible if we were only hearing these messages from drug company sales reps. But we were hearing these messages from pain specialists, eminent in the field of pain medicine. We were hearing it from our professional societies, from the Joint Commission, which accredits our hospitals. We were hearing it from the Federation of State Medical Boards, all of whom had financial relationships with opioid manufacturers. I would like to thank Ranking Member McCaskill for launching an investigation of these relationships. It is fair for you to ask about the role played by Medicaid, and it is fair to assume that access to medical providers offered by the Medicaid program could increase the risk that an individual would develop a disease frequently caused by doctors' prescriptions. I believe that access to prescribers that Medicaid, Medicare, and commercial insurance offers does increase the likelihood that someone might develop a disease caused by prescriptions. But I do not believe that Medicaid should be singled out in this regard. Opioid overdoses have been increasing in people with all types of insurance and in people from all economic groups, from rich to poor. If you look at this graph, it's from a recent Health Affairs paper. Excuse me. You'll see the orange line at the top of this graph that represents people admitted to hospitals being treated for overdose insured by Medicare. You could see with all of the colors of the lines rising on this graph, they show that we've seen a rise in hospital admissions for opioid overdoses for all types of insurance. But what we see on this graph is that the fastest growing share of hospitalizations for opioid overdose has been Medicare, not Medicaid. Medicare beneficiaries went from the smallest proportion of these hospitalizations in the 1990s to the largest share by the mid-2000s. I also do not believe Medicaid expansion is making the epidemic worse. Medicaid expansion is not responsible for the very sharp increase we've seen in opioid overdose deaths over the past few years. The reason we're seeing a sharp increase in opioid overdose deaths, as you know, is because of fentanyl. Medicaid expansion has not led to more aggressive opioid prescribing. Since 2012, we've seen opioid prescribing trending down, thank heavens. The opioid crisis is getting worse, again, most rapidly in the states that have the most fentanyl. Chairman Johnson, you've made the point that Medicaid is not a silver bullet for tackling opioid addiction. I agree with you. Medicaid is far from a silver bullet. With regard to improving access to effective addiction treatment, Medicaid is necessary, but it is not sufficient. The addiction treatment services that health insurance, including Medicaid, can pay for must also be available. The first-line treatment for opioid addiction is buprenorphine, also called Suboxone. Access to this treatment is not sufficient. For opioid-addicted individuals who are fortunate enough to access buprenorphine, too often their health insurance, including Medicaid, is only paying for the prescription. Patients with insurance must often pay out of their own pocket for the visit to the doctor. This is because there are not enough doctors prescribing buprenorphine, and the few who do not accept insurance, including commercial and Medicare. And many state-licensed drug and alcohol treatment programs that do accept Medicaid are not offering medication-assisted treatment. If you look at the last chart with these horizontal lines, that's showing you individuals who are receiving medication-assisted treatment within the state-licensed system. The fact that these lines are pretty much flat shows that despite our worsening opioid addiction epidemic, we have not been increasing access adequately to medication-assisted treatment. If we want to see opioid overdose deaths start to decline, there will need to be a massive federal investment to build a treatment system that does not exist yet. I believe Medicaid is a necessary ingredient to make these programs viable. We must ensure that in every county in the U.S., an opioid-addicted American can walk into an outpatient treatment center and on that same day receive effective treatment regardless of their ability to pay for it. Until that happens, I believe overdose deaths will remain at record high levels. Thank you.
Thank you, Dr. Kolodny. I'm going to defer my questions except for one. And if you quick put up the chart, the opioid-related hospital stays, because you had a similar chart, and I just kind of want to get your reaction to this. We actually developed this off of the hard numbers in terms of the numbers of tens of thousands of people, but we just did this as inpatient stays per 100,000, difference between Medicaid paid versus private insurance paid, and it's a pretty large difference dating back many years, with a slight uptick from about 350 per 100,000 to close to 450 per 100,000 for Medicaid paid. Can you kind of explain that difference right there?
It would be difficult to explain without reading through the full paper. The chart that I showed is from a Health Affairs paper that was published a few weeks ago, which has very current data in it, and I'm more familiar with that data. Those were hospital admissions involving opioid overdoses, and what we saw on that chart was a very significant rise for all payer types, including self-pay. And what we saw in the Health Affairs paper is a very substantial increase for Medicaid, but an even greater increase for Medicare.
Medicare, okay. Again, these numbers come from Health and Human Services, and all we did is just take it and put it to, number per 100,000, just to make it a little bit more relatable. With that, I'll turn it over to Senator Peters.
Thank you, Mr. Chairman, and thank you to each of our witnesses for your testimony today. And if I could summarize what I heard from everyone, hopefully it's as accurate, as that there is a recognition as to how important Medicaid is as a health provider for Americans who have the ability to access that, and that health care should be a quality health care that's affordable and accessible to everyone. And this is not an indictment on that part of Medicaid, that we're going to continue to strengthen that if we can and make it work better. But there are some issues that we should be talking about, and certainly dealing with the opioid addiction. These are important issues that should be discussed, and we should figure out what's going on. Dr. Hyman, Dr. Calandri, I want to pick up on your comments in particular and have you expand. I understand that Medicaid beneficiaries do fill more opioid prescriptions. We do know that from some of the evidence out there, but I also know that during your time in New York City, you worked with Medicaid beneficiaries extensively. You served as a Medicaid provider at one point. Can you help this committee understand why Medicaid patients, particularly individuals who qualify through disability and other issues related to that, would be prescribed more opioids? Is there something unique about the Medicaid population that we should be aware of?
Yeah, I'm not. I'd really like to see that data. I'm not certain that we see far more opioid prescribing in Medicaid populations. One of the populations, for example, where we've seen very aggressive prescribing would be workers' comp. We see very aggressive prescribing in Medicare Part D. We know that people with access to doctors, and in particular people who are prone to injuries, are going to be, and older people who are going to complain of pain are going to be most likely to be prescribed opioids. It is older Americans that are receiving the most opioid prescriptions.
Dr. Hyman, if you could talk a little bit about some of the work that you've done in this area and tracking use from folks in various medical plans as well. There is certainly a difference in what we've heard here is that wherever there's been Medicaid expansion, there's increased opioid use and addiction. That may very well be a correlation, and correlations do exist, but it doesn't necessarily mean there's causation. Do you believe this is merely a correlation, or is there also causation that Medicaid expansion has led to increases in opioid addiction?
I believe it's correlation.
Simply correlation. Would you elaborate?
To be correlation, not causation. I'm sorry, I neglected
It's on.
my thing. Based on the evidence I've seen, I would classify it as correlation, not causation.
Could you expand on some of that evidence?
You know, the first thing that you, and this is a general observation that I tell my students, just because A comes before B doesn't mean that A causes B, right? You need to look at pre-existing trends. And if you look at pre-existing trends in the states that expanded Medicaid, you see that they had higher opioid usage before the Medicaid expansion, which obviously was 2014. And so, you know, if you need to control for that prior trend in order to infer whether there's a sort of bump that's attributable to Medicaid. But even then, you need to control for other differences between the states that didn't expand Medicaid. And you can't do that just by cherry picking individual states. The other thing you want to do, obviously, is look not just at the states that expanded Medicaid, but also the states that didn't expand Medicaid. And see what happened there, and look at the states that expanded Medicaid that didn't experience, you know, finding themselves at the top of the distribution of states in terms of their death rate. And so, you know, just because A precedes B or seems to go along with B doesn't mean that A causes B. It's sort of statistics 101.
You also talked in your testimony about some of the structural aspects of Medicaid. And I've heard directly from physicians in Michigan with concerns that insurers and federal health programs, in particular like Medicaid, also often have policies that limit access to less addictive pain medications. I think our goal should be to look for alternatives that are not as addictive. You mentioned the issue in your testimony briefly and suggested that we need to change the ways that we reimburse for certain pain management treatments. So within our federal health programs, how can we do more to incentivize less addictive pain treatments?
So to the extent less addictive pain treatments are more expensive, you're going to need to start paying for more expensive pain treatments rather than just the cheapest one. And that's an issue that, as my written testimony indicates, has been leveled against private payers as well as public payers. Second is you basically need to move away from an open-ended passive payer of bills to a much more active monitoring role in dealing with the, thankfully, relatively small number of true bad actors, but also creating better incentives for both providers and patients not to overprescribe opioids nor to abuse them.
Dr. Chladni, in your written testimony, you talked about the need to improve access to medication-assisted treatments. And I have recently introduced some bipartisan legislation with Senators Capito and Murkowski in the Senate called the Youth Act, which aims to increase access to these treatments, particularly for young adults and adolescents, who, as you know, are often precluded from receiving these treatments. I would like you to comment on that and whether or not it's necessary for us to expand some of these treatment options for adolescents who are also very susceptible to these addictions.
It absolutely is necessary, and adolescents are a group that may have even less access to some of the most effective treatments for opioid addiction because of the bias or stigma against treating opioid addiction with medication. Something I'd just like to add a little more to was my comment about patients not having access to buprenorphine treatment paid for by their insurance. What is all too often the problem is that patients can access the medication. Their Medicaid or their private insurance will pay for the prescription, but there really is not enough access to treatment programs that accept the patient's insurance. So with Medicaid expansion, I think there are people who now are on buprenorphine for their opioid addiction because they have Medicaid that will pay for that prescription, and that prescription may be keeping them alive, but the Medicaid expansion hasn't helped them access the visit. And if we really want to see overdose deaths go down, where we want to be is in a place where someone who's opioid addicted, when they get up in the morning and they're going to need to use very quickly after they get up, or they're going to be feeling very sick, People who continue to use, it's not because it's fun, they're using because they have to keep using to avoid feeling awful. If, for that individual, finding a treatment center that can treat their opioid addiction with medication is more difficult, more expensive, they have to pay that doctor out of their own pocket, even if they have the prescription coverage. If all of that is more expensive than than calling a drug dealer and buying a bag of heroin, they're going to buy the bag of heroin. If we want to see overdose deaths come down, we have to change that balance. Effective treatment for opioid addiction has to be easier and less expensive than buying a bag of dope if we want to see deaths come down.
Great, thank you.
Before I turn it over to Senator Paul, I just wanted to chime in one more time, put up this one chart. Again, I think I've been very careful. Let me repeat. I agree that correlation doesn't mean causation, but this was an analysis that we got from HHS last year. And what they're just trying to show is, anecdotally, they compared states with similar type of demographics, similar type of population, expansion versus non-expansion. And, from my standpoint, the results were somewhat stark. West Virginia, 27% increase in overdoses, Mississippi, 11, Ohio, 41% versus Wisconsin, 3, Maryland, 44, Virginia, 22. New Hampshire, 108 versus Maine at 55. North Dakota, 205% versus South Dakota at 18. Again, expansion versus non-expansion. Again, not saying it's causation, but it's this kind of information that would, I'll just ask Dr. Hyman, at least makes you curious and something ought to be further explored, don't you believe?
Oh, I certainly agree it should be further explored. And, you've got 10 states, they're obviously 50. Right.
Right. And again, this is just an analysis based on data, not a scientific study by any means. But you've got other data.
I certainly
it also says once Medicaid has been funding this, you throw more money into Medicaid, it might kind of help fuel it as well.
I think it's certainly worth study. I would note that the 4 states on the right have relatively low populations, and so even a small increase can have a big percentage impact. This is part of the process that you have to go through.
Again, all I'm saying is it's worth, it's not worth dismissing. Let's put it that way. We shouldn't dismiss it. Senator Paul.
I think we can argue that the increase in opioids that we've seen with Medicaid expansion might be unintended, but I don't think we can argue that it's unforeseen. You can argue causation and correlation all day long, but if Medicaid population was using opioids at a greater amount than the non-Medicaid population before the expansion, if you give Medicaid more money, you're going to see the same thing, and more money will simply exacerbate something. So if they were using prescribing opioids at twice the rate before, maybe they're still doing it at twice the rate. So Medicaid expansion didn't cause prescribers to prescribe it more, but if they're already doing it and you fuel it with more money, you're going to get more of a problem. So I think it's very predictable. And if you throw more money at Medicaid now and you don't have rules on prescribing or you don't have significant changes on prescribing, you're going to get more of the problem. I agree with some of the issues on Suboxone and replacement and rehab. All of those things would be good. But if you don't fix the rules on prescribing, and normally I would say this is a state problem and we shouldn't be involved, but all the money's federal now, so it's 100% federal on the Medicaid expansion. So I guess one question I would have for the chairman is, do you have any ideas or thoughts about, we want to do problem solving, about how we would change the prescribing habits other than just suggestions? I think suggestions aren't enough actually here.
Well, again, I'm not the witness here, but it's actually what I want coming out of this hearing is give that thought process. One of the reasons I've written a letter to HHS. Let's get the information, let's get the data, and then work with experts. What can we do to change the prescribing methodology, those types of procedures so that we stop overprescribing and we can actually effectively address this?
Mr. Adolphson, do you have any ideas on how we'd change prescribing habits through law?
Thank you, Senator. There are a couple things that are already in law that I think states aren't using well. I know Maine wasn't when we arrived there. Prescription monitoring in the Medicaid program. There's a program called Lock-In where you restrict a Medicaid member to one pharmacy, one doctor, one prescriber. Those programs not used very effectively or not used extensively in states. There's somewhat of an obsession with access in the Medicaid departments around the country, I think, and so it seems that folks are sometimes shy to do things that might restrict someone from that access. But I think the lock-in program is good. There are other controls, certainly. There's a drug utilization review program that's already in Medicaid, again, but not being used well. The bottom line is the money flows through Medicaid, and people, I think, view Medicaid as more than it is. It's really, as somebody, another witness said, a passive payer. And so they're not looking at a person holistically. And, you know, causation, I've seen it line by line. I've seen a person access their welfare benefit, and a couple days later, we see them in the data with an overdose. And that's causation. And I think we can find that level of detail if you look at the states, but it needs more control.
And I think, though, overall, we're going to need a much more dramatic change in how we prescribe. I mean, Sam Quinones in his book talks about that used to be physicians were worried about addiction, and in chronic pain, we didn't tend to use opioids as much. And some of this came from Big Pharma, you know, trying to change patterns of prescription, came from within the pain community, and it came from distorting one study that talked about inpatient people on opioids that had really nothing to do with outpatient treatment, and was misused to say that we could use opioids in an outpatient without any consequences. So I think it has to be very, very dramatic, and I think it's going to have to actually be in law. As much as I'm for freedom of the physician to prescribe stuff, if it's federal money, we're going to have to oversee the federal money, and we're going to have to figure out a way to say, you know, maybe other than terminal patients and a few other people, it needs to be something else. And you talk about expense. I've had a lot of experience with pain myself. Ibuprofen, I think, works in a fabulous way and is very cheap. But we've convinced patients that it's not good unless it's prescription, unless it's good stuff, unless it's a narcotic, it's somehow not a good painkiller. But ibuprofen is a very potent painkiller, particularly in higher doses. But something dramatic is going to have to happen. And I promise you, if we just throw more money at this, the problem will get worse. We have one county in Appalachia, and we've gotten rid of the really bad doctors. We have done some of the controls that the states have tried. And last year, I think it was 20,000 people got 2.8 million doses of opioids in one county. 150 doses per man, woman, and child. And this is after we've spent years in Kentucky really rooting out the bad doctors and doing some good things, and yet it's still an enormous problem. So I think what we have to look at, Mr. Chairman, I think we have to look at the money. We're in charge of the money for the Medicaid expansion, and we're in charge of a good chunk of the Medicaid program. We need to put in place some rules on this, but it's going to have to be dramatically changing this. I'm not so sure OxyContin should be used for chronic pain at all. So, I mean, we really probably need to get away from that, but we can't have suggestions. What we tend to do up here is we write into law suggestions, and they never happen. This is a real epidemic, and we're fools to sit up here and say causation versus correlation. And people are dying in Medicaid, and we're giving it away for $3. If we can't get over the fact that you give people free medication and then we overprescribe it, that there's going to be a problem, we have to have significant rules in place. And Mr. Schock, you mentioned something about the payment with Medicaid, whether or not there could be more rules attached to how we pay people with for opioids that might lead to some improvement. Do you want to expound on that?
Sure. So, you know, in addition to, I said that I ordinarily it's the impoverished that walk through the courtroom doors, but I've also prosecuted, you know, a prominent medical doctor in my community for committing Medicaid fraud. And what that illustrated to me was how susceptible Medicaid patients are to being victims of doctors that are committing Medicaid fraud themselves. I want to say, as a whole, I believe the medical community is well-intentioned and is seeking out a healthier community. But as we all know, it only takes one bad actor in a community to really exploit an already dangerous situation. And so what we were seeing was that this doctor's Medicaid patients, his prescription practices were far different than his prescription practices with non-Medicaid patients. And due to how vulnerable that segment of the community is, whether that's through drug addiction, criminal behavior, what we were finding was they were being treated differently. And I think if you talk to any prosecutor in any part of the country, they're going to tell you all their defendants, they always have that one go-to doctor that they seek out. We call them pill mills in law enforcement because that's really how we view them. By regulating what the doctors are doing, and just like you, I am all for freedom in the medical community. However, I think we need to hold doctors more accountable. You know, are their prescriptions in line with the treatment program? As a prosecutor, it's very difficult to go after a medical doctor that's committing Medicaid fraud because they are insulated under this treatment of care defense. However, What is the difference between a doctor that is prescribing pills that are not necessary than the person that's dealing heroin on the street? They're both making a profit by selling something that is not needed. And so I think that we need to hold our medical community to a higher standard as it relates to the egregious prescription practices. I think you're absolutely correct, Senator, that we have to regulate prescriptions.
I'm going to burn up more of my first round time here. Your comment begs the question, how are they treating the Medicaid patient differently than their normal patients?
What we found was that the volume of prescriptions that were being prescribed what was different than the non-Medicaid prescription clients. Now, in the case that we had, it was a very intricate set of facts, but in terms of they were coming in testing dirty for meth, testing dirty for heroin, and yet they were still being given, more prescription after prescription. And that's from a medical perspective, I don't see how that is a viable or plausible solution.
I want to quick ask the doctors. We held a roundtable in Oshkosh, and I asked the doctors. I didn't intend to bring this up, but it ties into this. And I asked, we probably had a couple dozen doctors, and I just said, if there's one thing, this is about healthcare in general. If there's one thing that was a problem in healthcare, can you say what it was? And one doctor blurted out Medicaid, and they all shook their head. I go, and it shocked me. I go, what? Describe that. And they were talking about the high percentage of no-shows and appointments in Medicaid versus non-Medicaid patients. And the reason I bring it up, to what extent are doctors just giving somebody on Medicaid, just a month or 2 month supply of opioids so they don't have to schedule another appointment to have a no-show? Is that part of the kind of real-world reality that occurs? And I'll just have to ask the doctors on that. Legitimate question.
So I don't think that the problem is that you're describing it is unique to Medicaid. No-shows, for example, you could see it with patients with any type of insurance. I think there are problems that add to overprescribing that have to do with our healthcare system, so that if a doc has 10 or 15 minutes to spend with a patient, writing a prescription is usually the quickest way to get the patient out of your office. And, it was mentioned earlier about paying for alternatives to treating medicine and treating pain with medication. It's not so much that payers won't cover physical therapy, but if you're a doctor with 10 minutes to spend with a patient, finding an in-network physical therapist for your patient and making that referral is going to take a lot more time than writing the prescription, and usually the patient just wants the prescription. So I think we have a healthcare system that incentivizes treating lots of medical problems with the prescription pad.
Well, again, across the board, patients don't pay for the products they get by and large. Dr. Hyman, you want to quick chime in, then we'll go to Senator Lang.
Yeah, I certainly agree that writing a prescription is often an easy way to bring the clinical interaction to a close. I think that I have also heard from many physicians about frustrations of dealing with Medicaid. Sometimes that's about the populations that's covered by Medicaid. Sometimes that's about the Medicaid program itself, which has, bureaucratic rules and often pays slow and not very much. And that's at least the perception among physicians.
Thank you. Senator Langford.
Thank you, Mr. Chairman. Let me bounce several questions and give you a practical example of this, of what we've talked about already. In Oklahoma, there's currently a physician going through the process right now that saw 90 patients a day and was writing narcotics scripts to almost every one of them as they came through, 90 a day, on average between 15 to 30 seconds per person that he actually saw them before he's writing a script. So it is an issue that we have to resolve, and obviously locating these individuals and then identifying them and prosecuting them becomes exceptionally important. I have a different angle on this that I want to be able to bring up. Mr. Shaw, you brought up in your testimony about Suboxone. You brought that up as well. The question I have is, in your testimony, you had mentioned that is being diverted. That is a drug designed to be able to help people get off of narcotics. That is now being diverted to being on the street as well as a narcotic. Can you talk me through what you're seeing there?
Well, let me first, I'm not an expert in addiction, but from a street level prosecutor, we see Suboxone being heavily trafficked in our community. Now, the flip side of that is we see other forms of opiate treatment, like Vivitrol, for instance, is not. It's an injection, and we see the success rates far higher in our community with those having an injection as an opioid blocker as opposed to Suboxone. That's not taking away from the benefits of Suboxone, but I can tell you in southern Indiana, it is heavily trafficked illegally.
Okay, any other comments on that? Good. Go ahead.
I think that the diversion of Suboxone onto the black market needs to be understood. Many of the individuals who are buying Suboxone on the black market are using it in a somewhat self-therapeutic way. And I think with diversion of opioids onto the black market, there are really two things that you have to think about and that we would have to be concerned about. One is whether or not the diverted opioids onto the black market are causing new cases of addiction, or more people becoming addicted because of that diversion, which, if that's happening, it would be making our opioid addiction epidemic worse. And the other thing you would want to be concerned about is whether or not the diverted opioid is contributing to overdose deaths. In the case of diverted buprenorphine, buprenorphine is a very different type of opioid. Someone who is a young person who's interested in or curious about experimenting with opioids, if that young person makes the mistake of experimenting with buprenorphine, they're very likely to have a bad reaction to that drug. And it's not like they're going to be feeling lousy for a few hours and then they go home at the end of the party. It's a very long-lasting drug. They're likely to feel very sick. They're likely to not want to do that again. Where you can see people get a euphoric effect from diverted buprenorphine is if they're an experienced opioid user and they've been off of opioids, then they can feel good about it. So I don't think that diverted buprenorphine is becoming a recreational drug causing new cases of addiction. And one of the unique properties of buprenorphine is that it is quite hard to overdose on. It has a ceiling on its effect. So even a patient who takes an extremely large dose, or someone trying to get high by taking extra doses, is unlikely to overdose, is unlikely to have respiratory depression. So I think the existence of this black market for buprenorphine has more to do with the fact that we're not making that treatment available to the people who need it.
Okay, thank you, by the way. Senator Paul was mentioning as well, that we're trying to figure out some way to be able to actually come up with some solutions in the process of this. Mr. Adolphson, you had mentioned about pharmacy lock-ins. Oklahoma uses that, my state. Has that been successful, not successful? What have you seen in locations like that?
So my impression of it, Senator, is that it's being used in a number of states, but not very aggressively. So you might find in a state with hundreds of thousands of people on Medicaid, a couple hundred people in the lock-in program, because the parameters of
They're
it
identifying high risk.
Yeah, the parameters are designed, though, to, again, with access in mind. So
Okay.
they don't want to over.
What about states experimenting with limiting dosage for opioids?
I can say in my state of Maine, we were very aggressive a couple years ago in limiting both the strength and length of prescriptions. It was not without controversy, but the early data coming back from Maine is that it's been very effective.
What about electronic prescriptions rather than paper prescriptions for opioids?
In that same law that was passed in Maine, they did a required prescription monitoring program, requiring docs to enter it in each time. Again, not without controversy, but it has so far early on proven to be helpful.
Obviously, there was a question on cost on that for physicians. There's a difference in input in personnel time to be able to do it, as well as the equipment itself to be able to do it in the system. What have you seen on that versus what was threatened to be what the cost is and what the actual cost is in the transition?
I don't have the exact cost, but I know at the department level, we provided free training. We used a number of grants that we had got for fighting the opioid crisis in order to help educate doctors, go into a hospital, help set it up. I think that's probably something that is a good thing to do, help on the cost side. But it is, it's an administrative burden, but I would argue probably one that could be worth it in this case.
Mr. Tindall, did you all experiment with any of that in Tennessee?
Yes, sir. Senator, thank you for the question. We started our monitoring database in 2006. We didn't have anything before that, and we started in 2006, and we've had a number of enhancements since then. What we do is, and it's free to all physicians, any medical provider that is enrolled in is free of charge. And now we've had some enhancements where it's mandated that every medical professional has to enroll into the system, as well as the pharmacist. So we monitor any drug issued, prescribed, or dispensed in the state of Tennessee, 2 through 4. It's somewhat similar to CASPR program in Kentucky, and that's the only state we kind of communicate with.
That was actually my next question. Is there cooperation with other states in sharing that information? If you live in Memphis, that's very different than the number of states that you might have opportunity to be able to go outside of the state to be able to use it.
Right. There's 8 states that border Tennessee, and the only one that really we communicate with is Kentucky. That's the only ones we have a reciprocal agreement, I guess, to share the monitoring of prescription drugs 2 through 4.
But they could not use, for instance, Medicaid, which is just part of what we're talking about today, but the Medicaid portion of it, they couldn't use in an out-of-state pharmacy, or they could?
There's a number of rules, exceptions to all of that. Sometimes if there's an emergency and you're out of state, you can use your Medicaid benefits to do that. But I'm not sure about all those exceptions that go with that.
One last quick question on it. If you're buying Sudafed in Oklahoma, you've got to be able to show a driver's license to be able to do that, and it's tracked on just the usage of Sudafed regardless of where you get that. Is there any system like that that's been discussed or is in place on narcotics?
Very similar in Tennessee, you have to sign a log and produce a photo ID to get Sudafed.
What about for narcotics?
Part of our controlled substance monitoring database now, you have to present an ID when you pick up any kind of narcotic from the pharmacy. You also have to do that as well.
Okay, thank
And
you.
just one more thing, if I could add, effective yesterday, with few exceptions, TennCare will only pay for a 15-day supply of opioid medication within a 6-month period. So we've reduced it significantly to get opioids for a 6-month period in Tennessee.
Okay, thank you. Thanks for sharing.
Senator Jones, your maiden line of questioning.
Thank you, Mr. Chairman. Having come from a state that did not expand Medicaid and probably has one of the most restrictive Medicaid eligibility requirements in the country, we still have an incredible opioid problem. And I appreciate Senator Paul's comments, because of what I'm seeing in Alabama is a prescriber problem more than anything else. And I'm curious, having been an old prosecutor myself, Mr. Schalk, can you give me an idea of, and I know this may be difficult, but how many of those folks that are being prosecuted for taking those prescriptions and selling the pills or doctor shopping, do you have an idea, a sense of how many of those people actually started out addicted to those opioids and they need the money? And that's driving it as well as just being generally impoverished.
Right. I think certainly addiction plagues the criminal justice system, and we often throw around the term drug dealer very loosely, and we have many kinds of drug dealers in the criminal justice system. We have those that deal for profit, and then we have those that deal to feed their own addiction.
Right.
I would say those that deal to feed their own addiction make up the overwhelming majority of those that are in our prisons.
Right. So if that's the case, do you have in process or have a process in place when you arrest somebody? You do those. Do they get treatment? Is there a drug court or something like that you can put these folks in to try to keep them out of the system a little bit better, but
Sure,
to try to
so-
deal with that addiction so there's not a recidivism?
We are blessed in my county to be small enough to have a tailor-made program for many of the individuals that are coming through the criminal justice system. If you go just a few minutes down the road to Louisville, which is obviously a much larger metropolitan area, it's much more streamlined. They just simply don't have the resources or ability. And so, yeah, I think having, being able to make a tailor-made treatment program for an individual is a key ultimately to their success. And that includes, and a lot of times defendants don't want to hear this, but being sober. And
Right.
when you are struggling with opiate withdrawals, in my opinion, the best place sometimes to experience those are within a jail where we know you're going to be sober, you're not going to go out, and you're not going to use again. But once we can have 90 days of sobriety, at that point we can then start exploring options, treatment programs that are available.
Right. I've also noticed in some of the, I guess, charts that we've seen, there seems to be, the private payers seem to be doing a little bit better in terms of the opioid problem. What are the private payers doing differently than Medicaid that Medicaid can learn from to try to stem the prescriptions to begin with, I think is a big problem. So I'll just throw that open to anybody that might have a proposal or an answer.
You know, the explanation for why in the past few years we're seeing, for example, less hospitalizations paid for by a private insurance versus Medicare involving opioid overdose is not really clear. It's possible, as your question suggests, that there are things that the private payers are doing that maybe Medicare or Medicaid should replicate. I'm not sure that that's the case. In the past couple of years, we have seen commercial private insurance companies begin to implement policies to promote more cautious prescribing, but it's been pretty new. One possibility is that for people who become opioid addicted, who fall out of the workplace because of their opioid addiction and become poor because of their opioid addiction, they may more likely wind up insured by Medicaid and fall out of the private system. So it's hard to say why we might see a greater problem in people insured by Medicare or Medicaid.
All right. Yeah.
Senator, I think it's because they're trying. You know, Cigna announced that they pledged to lower prescription painkillers by 25% in 3 years. So they've acknowledged they have a role here that they might be playing in this issue. So I think Medicaid hasn't acknowledged that. And it's a little ironic because Cigna's using the CDC's guidelines, you know, the CDC right down the street from Medicaid, but they haven't seemed to get together on it. So I do think there's a level of acknowledgement and effort that the private insurers have made.
What about the role of the prescription drug companies that are manufacturing these opioids? What role should they play, Dr. Haim?
Well, something that the manufacturers of opioids should stop doing, and I think something the Food and Drug Administration could require them to stop doing if it properly enforced the Food, Drug, and Cosmetic Act, they should immediately cease promoting opioids for chronic pain. As Senator Paul mentioned earlier, opioids have not been shown to be safe and effective for long-term use for common chronic conditions like low back pain, fibromyalgia, chronic headache. These are good medicines to ease suffering at the end of life. They're good medicines when you're using them for a couple of days after major surgery, but for daily long-term use, they may be more likely to harm the patient than help the patient. And right now we have a law that says that drug companies are only allowed to promote products for conditions where the benefits are likely to outweigh the risks. In those conditions, they become the indication on the label, and if the company gets caught promoting use not on the label, they get into trouble. The label on opioid analgesics is very broad, which has allowed the manufacturers to promote for conditions where we really shouldn't be prescribing opioids.
Anybody else want to take a shot at that? Otherwise, Mr. Chairman, that's all I have. Thank you.
I just want a quick follow-up. I mean, that's a problem with FDA approval on that particular drug, right? I mean, too expansive a approval?
Yeah, I mean, if we could go back in time to the introduction of OxyContin, if FDA had properly enforced the Food, Drug, and Cosmetic Act, they would have told Purdue, great, you've got extended-release oxycodone. That sounds like a good drug for cancer patients. We're going to let you send your sales force to the hospices and to the oncologists and to palliative care doctors. FDA didn't do that, and there wouldn't have been that much money for Purdue to make if their product had only been prescribed to patients at the end of life. So they promoted broadly, and FDA allowed it. But with every manufacturer of opioids, they've done the same thing because the big market is chronic pain. Millions of Americans suffer from chronic pain. That's where they're going to make their money, and so that's what they've been promoting use for.
Well, it's never too late for the FDA to change it.
That's correct, and our new FDA commissioner may be finally the FDA commissioner to do that. He certainly made some statements leading us to believe he may take some of the steps necessary.
Okay, I'll follow up later.
If I could just add, I would point out, once the FDA approves a drug, physicians can use it for off-label indications. They don't require the FDA's permission. And once it's been approved, there are, notwithstanding some people's views on the scope of the FTC, the Food and Drug Cosmetic Act, there are serious constitutional questions raised by attempts to prohibiting pharmaceutical companies unless they're engaging in false and misleading speech.
Okay, Senator Harris.
Thank you. Dr. Kolodny, I was struck by your fourth slide, which showed that hospitalizations for opioid overdose are increasing most rapidly, as you have mentioned, in Medicare, but also increasing for people with private insurance and people without insurance and people with Medicaid. These facts make it clear to me, at least, that diversion is a risk regardless of the type of insurance coverage a person may have. To follow up on this conversation, in 1996, Purdue Pharma released OxyContin, an opioid that they falsely claimed would deter addiction, as you have mentioned. In the 5 years, from 1997 to 2002, OxyContin prescriptions grew from 670,000 to 6.2 million. And overall sales of prescription opioids increased roughly 4 times between the years of 1999 and 2014. A number of senators, Senator Claire McCaskill and myself included, have ongoing investigations of drug companies and distributors who helped cause and exacerbate the opioid epidemic. To that end, you've mentioned a bit about what the FDA responsibilities are. Can you talk about what you believe Congress can do to hold pharmaceutical companies responsible for its role in causing the opioid epidemic?
That's a really good question. Well, I think one thing that Congress could do is hold FDA's feet to the fire through your oversight role of FDA, because FDA really has failed to enforce properly enforce the laws and has allowed opioid manufacturers to improperly promote opioids. I do think that I'm very pleased by your investigation and Ranking Member McCaskill's investigation of the role that manufacturers have played. I do want to point out, though, that Senator Grassley and former Senator Baucus launched a similar investigation in 2011. The Senate Finance Committee began an investigation, and the Senate Finance Committee has yet to release its findings from that investigation. So I think making those findings public would be very helpful. I think for changing the behavior of the manufacturers, many of the organizations or front groups that they give money to, they're continuing to fund, and these are front groups that are blocking federal and state efforts to promote more cautious prescribing. The Associated Press and the Center for Public Integrity did an investigation showing that the opioid lobby, the manufacturers, the distributors, have spent more than $880 million over the past decade blocking efforts to promote more cautious prescribing. And I think the findings from these investigations may make it more difficult for them to continue doing that.
And you mentioned front organizations. Can you talk about who and what they are?
These would be organizations that in some cases are pure AstroTurf organizations created by industry.
AstroTurf, what do you mean?
AstroTurf is an organization meant to look like a grassroots organization, but it's been artificially created by industry. One of the organizations that was very damaging was the American Pain Foundation, which was an AstroTurf organization that shut down on the day that the Senate Finance Committee launched its investigation. There are also medical societies, professional organizations that front group might be a bit strong, but that take very significant funding from opioid manufacturers and promote the interests of opioid manufacturers rather than the interests of patients. So, for example, the American Academy of Pain Medicine, the American Pain Society have promoted very aggressive prescribing of opioids and have really come to the defense of manufacturers every time efforts are raised that could potentially better regulate them.
Thank you, and I plan to follow up on your suggestions. Thank you. Medicaid is, of course, one of the leading sources of substance abuse treatment, covering about 1/3 of opioid addiction treatment. In June of last year, I toured and met with the patients at the Martin Luther King Jr. Outpatient Center in Los Angeles. I will tell you that Medi-Cal pays for 70% of the care there. The Nonpartisan Government Accountability Office found that Medicaid expansion increased access to substance abuse treatment, and the Urban Institute found much more rapid growth in spending on opioid treatment medications and overdose reversal medications in states that expanded Medicaid, suggesting, of course, that more of those who need treatment are getting it thanks to Medicaid expansion. The President's own opioid commission called for the expansion of Medicaid by having the administration grant waivers for all 50 states to eliminate barriers within the Medicaid program in order to help more people have access to treatment. My question is, if Medicaid funding is cut, what happens to the 1 in 3 people who receive treatment under Medicaid for opioid addiction?
So I think that there are individuals right now who are, thanks to Medicaid expansion, alive, who are having their opioid addiction effectively treated. If they were to lose Medicaid coverage, for example, I think that there would be a very high likelihood that these individuals would relapse. And if relapsing, a high likelihood that they could die from an overdose. We have an exceptionally dangerous black market opioid supply. We have never had heroin as dangerous as we do today because of fentanyl that's in it or fentanyl that's sold as heroin. A relapse is not a benign event. One relapse can be fatal, and if patients lose health coverage that's paying for their addiction treatment, they're at very high risk for relapse and loss of life.
Thank you. And Mr. Schalk, I appreciate your comments as a fellow prosecutor. I think we both appreciate, and certainly your work has pointed this out, that one of the best ways that we can be smart on crime is to follow what the public health model has taught us, which is if you want to deal with an epidemic, be it drug, crime, or health, one of the most effective and smartest and efficient ways to deal with it is not reacting after, but actually preventing before these crimes occur. So I appreciate your comments and the work that you've done highlighting that point.
Thank you,
It's
Senator.
in the best interest of public safety and also taxpayer dollars.
Thank you.
Thank you, Mr. Chairman.
Senator Hoven.
Thank you, Mr. Chairman. I expect each of you have looked at Chairman Johnson's chart on the rise in overdose deaths, increase from 13 to 15, comparing a number of expansion and non-Medicaid expansion states. So I would ask each of you, starting with Mr. Adolphson, to what do you attribute that? Thank you for putting the chart up. And to what do you attribute it? What's causing it? What should be done about it?
Thank you, Senator. I think we've heard from a number of folks, not just in this testimony or in this hearing, but in previous hearings, that we have a real supply side problem on opioids. And I think when you're in a hole, you stop digging. And expansion has really opened the door to a massive increase in these opioids in the market on the supply side. So I think when you look at a state that has expanded, that's added hundreds of thousands of people who suddenly are not just eligible for the treatment that we've heard about, but they're also eligible to receive no-cost prescriptions, you're inevitably driving up the supply of this into the market.
And what should be done?
Well, I think there are some options. One of the things that ought to be considered is maybe disconnecting substance abuse treatment from the rest of the benefit. So, for example, there obviously are millions of Americans out there who need substance abuse treatment. No one would argue that fact. However, is it best delivered with an entire Medicaid package that includes access to more opioids? And that's really the problem that I saw was we had folks over on one side of the house getting treatment, and those same folks were still getting opioids that caused the addiction in the first place. And those two kind of butt heads. So I think it doesn't necessarily have to be one without the other. The substance abuse treatment should be very targeted and focused and not necessarily come with all of these unintended consequences.
Mr. Schock.
Senator, looking at these numbers, what's clear to me is when we give more prescriptions, when we give greater access to those that are most susceptible to addiction, that are most susceptible to the criminal justice system, at a certain point, they're going to transition from these opioids that a doctor's prescribing, and they're going to start seeking their high from somewhere else. Perhaps that's because the doctor said, I'm no longer going to write you a prescription, I can't justify this. And at a certain point, when they transition from the pills that their doctor's prescribing them, and they transition from there to to fentanyl and heroin laced with fentanyl, that's where these deaths are coming from. It's from injecting heroin and no one just starts on heroin. It's a progression, and almost without fail, before someone begins down the path of injecting heroin, they are abusing their prescription pills. And I think just looking at the fact when we are making these prescription pills more readily available to a greater segment of our population, this is what happens.
And what should be done?
I believe that while this is a multifaceted issue, we need to hold the medical community more accountable would be one key aspect as it relates to their prescription practices. We are giving doctors in many ways complete discretion to prescribe synthetic heroin, and that's a lot of power. And so I think we need to take a closer look at the prescription practices. Are they in line with the treatment plan? Are they improving quality of life? And if those answers can't be met, then we need to hold the doctor accountable as to why were they prescribing this unneeded and unnecessary drug to this individual.
Mr. Tyndall?
Thank you, Senator. And excuse me, I don't know that I could speak to expansion, non-expansion. That's probably above my pay grade in Tennessee, but certainly I think that the more people who have access to low-cost and no-cost prescription drug medication, the probability of drug-seeking behavior and prescription drug diversion increases.
What would you do?
Well, I think that it ought to be penalties if you're involved in drug-seeking behavior or selling your medication, especially by Medicaid. The penalties need to be a more severe penalty for that.
Dr. Hammond?
So I'd echo what's been said about the supply side aspects that, there are physicians who will write prescriptions for opioids, and there are patients who will take them and get those prescriptions filled. And that's a gateway for some of them to more severe drugs once they're cut off. I think on the solution side, so far we've talked a lot about the patient and doctor shopping. It's important to recognize, as I said at the outset, it takes a physician to write the prescription. And so we ought to be looking for outliers in the frequency of prescribing, both the relative to the patients that they're seeing and also relative to the doses that they're basically writing on the prescription pad. And, you may be an outlier because you're in the pain management business and you see a population of patients that badly need pain management. Or you may be an outlier because you'll basically write a script for everybody who comes through the door. And my suggestion would be not necessarily criminal sanctions as your starting point, given the difficulties that Mr. Schalk's already talked about, but some combination of financial incentives and licensure sanctions. State medical boards ought to be more active in this space.
Dr. Chladni?
So I think this is an interesting association, and it's worth investigating to see if this really holds out. If you were to compare the specific timeframes of Medicaid expansion and were to look at states, and it's certainly worth looking at. I do believe that we've got a good understanding of why the opioid addiction epidemic is getting worse and why in states where it's gotten much worse, why that happened. Something that's important to understand is we have two groups of Americans who are opioid addicted. We have a younger group and an older group. The older group are people who are becoming opioid addicted mostly through medical treatment. That older group hasn't been turning to the black market. They are getting opioids prescribed to them for chronic pain. Up until around 2011, we were seeing most of the overdose deaths in older people getting pills prescribed to them by doctors. It's possible in that older group, because prescribing has become a bit more cautious, overdose deaths may be stabilizing, coming down a bit. The younger group are people in their 20s, 30s, 40s, early 40s. They're becoming opioid addicted from using prescription opioids, either medically or recreationally, or sometimes a combination of both. That younger group, when they become opioid addicted, has a hard time maintaining their supply visiting doctors. Doctors and dentists, as we've been discussing, are too comfortable giving young people lots of opioids, but we don't like to give healthy-looking 25-year-olds a large quantity on a monthly basis. So the young person who becomes opioid addicted winds up on the black market. The pills are very expensive on the black market, and something we've seen happening steadily over past 20 years is a rising use of heroin in these young people who wind up on the black market and switch to it because it's much cheaper. Beginning in around 2013, overdose deaths in this younger group, in the group that's been switching to the black market, the group that's been using heroin, overdose deaths are soaring because of fentanyl, because the heroin supply is so dangerous right now. I think that is really the primary driver. I don't believe it's Medicaid expansion. I don't think Medicaid expansion is helping us as much as it could in terms of addiction treatment because the services are not there. I think people are getting their prescription paid for. So we have to do a lot more if we want to see overdose deaths come down. But I don't believe that overdose deaths are rising because of Medicaid expansion. I think it's fentanyl that's causing the very sharp rise that we've seen in recent years.
Thank you. Thank
Senator
you.
Daines.
Mr. Chairman, thank you, and I want to thank the chairman for producing this report. It raises some serious questions about whether Medicaid expansion is having a counterproductive impact on the opioid epidemic by proliferating prescription opioid pills. I come from a state that is an expansion state. It's the state of Montana. I'm particularly concerned by the report's exposure of how Medicaid expansion dollars have resulted in addiction among some recipients and facilitated illicit distribution of these drugs to others struggling with substance dependence. In short, the report provides, I would argue, a more complete picture on the consequences of Medicaid expansion, and we must not ignore its conclusions. First question, Mr. Adolphson. You mentioned in your testimony that 52% of able-bodied adults on Medicaid do not work, and that only 16% work full-time. Can you share more about the positive correlation that you have found between having a job and reducing drug dependency among healthy, working-age Americans?
Thank you, Senator. That's right. That data that you referenced is very clear. The number of able-bodied adults on Medicaid has quadrupled from 7 million in 2000 to 28 million today. Half of those do not work at all. We know from the addiction specialists, the recovery community, that work is a pillar of recovery. And certainly in a program that is paying for the amount of substance abuse that treatment that Medicaid is, I think it makes a lot of sense to encourage and assist people getting back to work. Unfortunately, it's not what we see. We're seeing the roles, particularly for able-bodied adults, continue to grow, and many of those people are not working at all.
Are you aware of what percentage of able-bodied Medicaid recipients actually return to full-time gainful employment?
Well, what we're seeing is enrollment continue to go up. So if they were moving into full-time employment, if you work even at minimum wage full-time, you're out of poverty. So if folks were quickly getting back in the workforce, working a full-time job or a couple part-time jobs, they would quickly cycle off of Medicaid because they would be earning income above the threshold. That's just not what we're seeing. We're seeing folks come onto the program, stay on the program. So unfortunately, that's an indicator that it hasn't been successful at returning people to work the way we would like to see.
Why is that? What do you see? I mean, it's usually all about incentives. what's the incentive to stay on Medicaid versus move and become gainfully employed?
Sure. There are probably a lot of things that go into that, but I think one thing we probably can all agree on is we all need deadlines and a push in our life to accomplish certain things. And Medicaid has been free of any requirement for kind of community engagement or work activities. That hasn't been a hallmark of the program, which historically might have made more sense when there weren't able-bodied working-age adults on the program. But as I mentioned, that number has grown dramatically with the expansion under ACA. And I think that kind of incentive structure is needed within the program to help clear that pathway and encourage people to get back into the workforce or into training or volunteering in community engagement.
Medicaid's been held up as a cure-all silver bullet for opioid treatment, which by its own right is critical to helping addictions. However, the evidence seems to suggest that Medicaid is a two-edged sword by proliferating prescription opioid pills due to the ease of access. There's always going to be leakage of diverted prescription opioids with or without Medicaid expansion. I think we probably would all agree with that. Mr. Adolphson, what makes those eligible under Medicaid expansion more susceptible to facilitating illicit drug diversion?
Thank you, Senator. I think we've heard a lot of great examples of that here in the testimony, of the temptation to turn a free prescription into several $1,000s and those types of things. I know one of the disconnects I saw in our Medicaid program in Maine was someone would have this access to Medicaid, and they might come into substance abuse treatment, possibly funded by Medicaid. But the success rate, unfortunately, is not very high in some of those programs, typically under 30%, sometimes in the teens. It's a difficult addiction to beat, so it's tough. So what happens if somebody's in treatment for, say, a week or a couple weeks even, but then they come out of treatment, and they still have the rest of their Medicaid benefit. They still have their pharmacy, full pharmacy benefit. They still have access to some of these other more dangerous drugs that may have led them into the addiction in the first place. So I think we need to do a better job of connecting those two dots within the program.
So when you look at those individuals who are getting hooked on diverted drugs, I mean, just kind of looking at the balance here of those coming on, those coming off, do you believe that more individuals are getting hooked on diverted drugs than successfully completing opioid treatment?
Yes. Yeah, 12.5 million people self-reported opioid abuse last year, painkiller abuse last year. And I think we heard from another witness already that something like a couple million people are trying to get into treatment. So it's pretty clear that on the supply side, the number of people misusing or becoming addicted is growing and outpacing the number of folks that are going into treatment and completing it.
Mr. Schock, in your experience as a prosecutor, and Mr. Tyndall as a Tennessee IG, you both have indicated the extent of Medicaid prescription fraud is unknown due to underreporting and other barriers. How expansive do you think the fraud might be?
Staggering. Based on the limited numbers that we see as opposed to what we know is going on, what we see is going on. I believe that if we were to look at the amount of Medicaid fraud that was happening just in my own community, members would be outraged.
So, staggering is a strong word. Outraged is a strong word. I guess maybe it goes back to my background in chemical engineering. I tend to be more of a quantitative guy. I know the chairman is a numbers guy, too. Do you have any sense of kind of trying to quantify the size of the bread box here without, staggering is related, there's something in your mind saying it's large. What, can you maybe try to quantify that for
To
us.
sit and quantify with a number, I wouldn't be able to do. I can only ascertain from my own experiences that I see from an investigative side, from a courtroom side. Unfortunately, Senator, I'm not able to sit and quantify with a particular number, so.
Mr. Tyndall?
Thank you, Senator. I can only echo what Mr. Shalkey says. It's just, I only have, to cover 95 counties in Tennessee, I have 14 agents. Have I had 100% of everybody 100% of the time? And we stay pretty busy just working the cases that we're aware of.
So what steps would you advise Congress? I mean, this is a great opportunity for you all to put it in the record here and to instruct this committee. What would you advise Congress, the states, or CMS do to take up to address this problem? A couple things.
Well, as has been echoed throughout this hearing, I believe that re-examining the prescriptions that are being written is an essential element to being a key part of the solution. And obviously, when doctors' bills are being submitted through Medicaid, it's no secret that the checks and balances are far less than when they are being submitted through a for-profit payer. So with that, I think when we are looking at prescriptions, is this prescription being written to pad a Medicaid fraud on behalf of the doctor? Is this prescription, again, is it improving quality of life? Is it medically necessary? Is it within the scope of the treatment? And frankly, can I go and get an over-the-counter that can be just as effective? As Senator Paul said, ibuprofen is very, very effective. However, an overwhelming majority of the people that come through my courtroom, they don't believe ibuprofen is appropriate. They believe they need a high-powered painkiller. And I think we need to, as a society, take a step back from that and say ibuprofen sometimes is appropriate. Now, it's not always appropriate, and I recognize that, but I think recognizing that ibuprofen is appropriate more often than not is a good step towards reducing this problem.
I'm out of time, Mr. Chairman. Thank you for allowing me additional time.
Well, I will say, when I finish up with my questions here, I'm going to ask the exact same question. So each one of you, if you had one recommendation in terms of a law change that would help solve this crisis, I'll give you that opportunity as well. But thanks, Senator Daines, for your questions. I want to start with two doctors and just ask the question, why did it take so long for the medical community to just recognize the extent of opioid addiction? Yeah, I mean, why didn't you have the feedback loop? You got, ongoing education, you have your medical journals. I mean, why did it take so long? And why did it take this epidemic to just burst onto the scene here before? And I'm not even sure all doctors are still aware of it. I hope they are. But,
Yeah,
but we just finished it. We held a roundtable in Wisconsin, and that's what I was shocked, is that you had an entire generation of doctors trained that these were not a problem. And again, that goes to marketing or whatever, but why wasn't this known really within a couple of years?
Yeah, that's a great question. I think for many years, the feeling in the medical community and even the position of the AMA was that the opioid problem was about the bad apples, that there were some doctors out there that are really drug dealers running pill mills, and that there are some people out there pretending to be patients, but they're really drug abusers and they want to get their hands on these drugs, and that the opioid crisis had nothing to do with well-meaning doctors taking care of their legitimate patients. I think that was the thinking for quite a while, when the reality is that the opioid crisis is really driven by well-meaning doctors who've been over-prescribing to patients, getting patients addicted, but also indirectly causing addiction by stocking homes with a highly addictive drug, creating customers for the drug dealing doctors, the pill mills, for the diversion and the fraud. So the bigger problem has been the well-meaning doctors. I think part of the problem, and it's not just the medical community, but policymakers, really for many years failed to look at the root of the problem, which was overprescribing. Instead, what they accepted was the way industry had been framing the problem and the way that the pain organizations funded by industry were framing the problem. What policymakers such as yourself were told was that all of this bad stuff that you're hearing about involving opioids, that's the drug abusers. There's a subset of our population that wants to get high off of drugs, And maybe because doctors are prescribing more, the drug abusers are getting their hands on these drugs. And yes, we should do something about the drug abuse problem and diversion, but let's not forget that tens of millions, 100 million Americans have chronic pain. They're being helped by these medicines, and that your job as a policymaker is to balance these two competing problems. You want to do something about the pain problem and do something about the drug abuse problem, but don't make the pain problem worse. Don't punish the pain patients for the bad behavior of the drug abusers. So it was framed as if we had these two distinct groups and the harms were limited to so-called drug abusers. Policymakers accepted that. If you look at what was coming out of the federal government, even over the past administration, if you look at what was coming out of SAMHSA, NIDA, ONDCP, it was almost an exclusive focus on the issue of non-medical use, kids getting into grandma's medicine chest. Nobody was asking, why does every grandma now have opioids in her medicine chest? Now we're finally asking that question.
The whole point of the PROP Act was to acknowledge the fact that government policy was requiring providers to ask the question, are you satisfied with your pain medication? If you got a bad survey result, it affected your reimbursement, which, so government policy actually fueled that. Dr. Hyman, at what point did the medical community all of a sudden wake up and go, this is a real problem? I mean, has it literally just been the last couple of years, even though this has been around for a couple decades?
I think it's quite recent. I think it's quite recent that the medical community has woken up to it, and you've already alluded to some of the incentives that they had to, I don't want to say not wake up to it, but to focus their attention on other areas. Lots of aspects of the healthcare system more or less run on autopilot. People keep doing things the way they were trained to do them. New information may not be available, or if it's available, they may say, oh, that's just one study. And this is not just about opioids, right? I can tell you story after story where there's a surgery or a treatment that gets deployed, it sort of spreads like wildfire. Subsequent research indicates that it's not such a great treatment, and it's very hard to stamp out once it's out there because the same sort of passive payer of bills creates an incentive for people to keep doing what they're doing.
So a one-number answer out of both of you, what percentage of the medical community do you think get it now, that fully understand it? Start, Dr. Hyman.
Age-related, young doctors get it. They've come of age during the opioid crisis. In some cases, they've lost peers to opioid overdoses. Older doctors, in my experience, doctors, and they're maybe older than 50, tend to still, many of them tend to be prescribing pretty aggressively.
So what percent? Only half doctors? 50%?
It's very, very difficult to give you an answer.
I realize I'm not going to hold you to it. Dr. Hyman, would you venture a guess?
I would guess that maybe a third of, it's a wild guess, that maybe a third of the prescribers are still very misinformed about that opioids and prescribing very aggressively.
They don't read the news? Dr. Hyman, do you
Well,
kind of agree with that? Or?
Even if they read the news, they may not view themselves as part of the problem, right? They may view themselves as treating with compassion and care the patients that present in front of them. If you made me give a number, I'd fall back on my medical school training where an attending told me there are only two numbers in medicine, 80% and 20%. So I'd give you the 20% number, which is a little lower. I think it's higher among younger physicians for the reasons that Dr. Kolodny's already alluded to. Circling back to the question about, the frequency of fraud and a quantitative figure, the standard figure in the literature is 10%. There's not a great empirical basis for that number, but if you add in waste and overuse, you can get much higher numbers. And I'm happy to share with you some of the research that's been done on that.
One of the questions we've submitted to CMS is how much are they spending reimbursing for opioids? That'd be just kind of a nice macro number to know. I want to switch over to the prosecutors and inspector generals. An indicator of the problem we have here is there's actually a website, and I'm not going to promote it, but there's a website you can check to see what the cost is to make sure you're not getting ripped off by your drug dealer in terms of these opioids. So, that's a problem. Can you speak to the relative cost of street heroin versus opioids? In any of you three?
I don't know that I can give any specifics, but my understanding is now because of the reformulation of some of the narcotics that we receive and that being harder to use and they're becoming more expensive, heroin is growing cheaper and cheaper by the day. So people are now turning to heroin as opposed to prescription drugs.
What we saw was at the pinnacle of Opana abuse, we had high school kids that were spending $200 a day on 2 Opanas, $100 a piece for a simple pill. Once that supply ran up and the formulation changed where it wasn't as easy to abuse, that's when heroin came in, and it devastated our community. And heroin, from our experience, has been easier to get, it's cheaper to get, and the effect, once you go down the road of heroin, you don't want to go back to pills because the high isn't as good.
Do people actually buy fentanyl, or do they buy it because they think it's heroin?
What we see are people buying heroin that is laced with fentanyl.
Okay. Yeah, I read something in a magazine article, $800 worth of fentanyl produces about $800,000 of street value. So if you've got the demand, the profit motivation is so high, you're going to have the supply. When I started this inquiry, again, it was based on that article, really talking about funding a lifestyle of non-working, supplying free health care and access to products that can sell as income supplement. In terms of our actual investigation, though, we found far more complex and larger schemes. And again, I want to ask the prosecutors, is that just because we really don't go after the single users, the people who are abusing it? We really are focusing what limited investigation, prosecution in terms of the larger ones?
I think like any law enforcement agency, we have to focus our resources and our efforts on the most prominent issues, and oftentimes that's the bigger players that we are going after. If we were to sit and we would need to expand our police agency tenfold to have to hold everyone directly accountable in our area.
But I mean, you were talking about, you think this is enormous. So you think it's enormous because individuals literally are using their Medicaid card or Medicare or VA benefits. They're getting the pills. They get a large. By the way, anybody know what an average quantity is? The doctors. I mean, what would be a typical monthly supply of one of these opioids?
Well, the vast majority of the prescriptions are written for acute pain. So if you're looking at numbers of prescriptions written, most of them are for acute pain, and they're for a small quantity.
Or short term. What about chronic?
So when you measure consumption in terms of weight of opioid consumed in the United States, in terms of a morphine equivalent, the bulk of our consumption is chronic pain, and the average patient is given a 1-month prescription with an enormous amount of opioid in it. So it could be about 70 milligram morphine equivalents or more per day. Some patients are on even greater quantities that are very dangerous. So
how many pills would that be, a day or a month?
Well, if you
let's say the average size in terms of milligrams.
So for a patient who's receiving opioids for chronic pain, they could be taking 1 pill in the morning, 1 pill at night, but each of those pills could be the equivalent of 25 or 30 Vicodin in 1 pill. So it would be the equivalent of taking 50 pills a day, only they're taking it in an extended release drug.
So, I mean, you really can, because the street value per milligram or whatever is, again, it's miles.
So it's about $1 a milligram. The most popular opioid on the black market is the 30 milligram immediate release oxycodone, which will do what a $10 bag of heroin will do. And the effect is actually almost identical. In fact, some people prefer the effect of oxycodone. They're using heroin because it's cheaper, not because it's a stronger effect.
Mr. Chairman, the prescriptions we're seeing sometimes is 90 to 120 pills per month, depending on the milligram. And hydrocodone tends to be kind of the drug of choice in Tennessee. And you may get 5 milligrams, 7.5 milligrams, or 10 milligrams. So depending on the milligram and the number of pills, if a person wants to sell 120 10 milligram pills, that's a pretty good chunk of change for a month's work.
So when you've got the difference between acute versus chronic, I mean, how are you going to control prescriptions based on chronic pain? I mean, you're not going to require a doctor to keep writing that every 3 days. I mean, that's one of the solutions sometimes is just limit to a 3-day supply, but that's just not, that may be appropriate for acute pain, for a dentist or something like that, but not for chronic pain.
So for chronic pain, we shouldn't be putting patients on long-term opioids. We have to prevent new starts. For the vast majority of these patients, opioids are not safe or effective. And I think that's been one of the main goals of the CDC guideline, is to prevent more people from winding up on long-term opioids. We have about 10 million Americans who are on opioids chronically, so many Americans on opioids chronically, that we're seeing ads on television for drugs to treat the side effects of being on opioids chronically, like constipation. These 10 million Americans who are on opioids chronically, many of them may not be able to come off. Even though the medical community is figuring out we shouldn't have started them on opioids, we also don't want them to cut them off abruptly. We have to try and help some of these patients come off. Some of them can come off. Some of them need addiction treatment. Some of them may just need to be maintained on safer, lower doses of the medication they're already on. The trick is to prevent more people from winding up stuck in their shoes.
So Mr. Adelson kind of quoted some figures in terms of, unfortunately, the ineffectiveness of treatment. Can the doctors speak to that? What kind of success rates do we have? And also just in terms of Suboxone, does that also give a high? I mean, why would that be diverted and be able to be sold?
So you can, if you're an experienced opioid user, and let's say you're in jail, so you've been off of opioids and somebody smuggles buprenorphine, Suboxone into you in jail and you take it, you'll feel a strong opioid effect as if you've just used just about any opioid. If you're taking buprenorphine the way you're supposed to on a regular basis, you're not feeling high from it. Patients feel normal. They look normal. I've had patients who are physicians who I would allow them to operate on me while they were on buprenorphine treatment. People can function very well. Most patients who are treated with buprenorphine do well. More than half of patients have good outcomes. Some younger patients with more severe opioid addiction, when you try and treat them with buprenorphine in the first year or so, they don't do that great. They come on and off. Sometimes they'll trade it. But it is the first-line treatment, and people who stick with it have good outcomes, and it is more effective than the Vivitrol monthly injection.
Successful treatment under Suboxone, how long does that take? I mean, is that taking
some-
that for months, years?
We don't know. What I can say is that short-term use of buprenorphine, Suboxone, doesn't work well. When patients come off, they're at very high risk of relapse. So we are talking about a longer-term treatment. Some patients, maybe it means for the rest of their lives. I would hope not. I think there are people who can come off, and maybe we'll come up with other treatments for opioid addiction so that there are better options available.
How often do they take that?
It's taken every day. Some patients will
just
take it in the
once a
morning.
day?
Yeah, once a day or twice a day.
And so we would probably have to make sure that we test to make sure they take.
You want
so
to,
that
yes,
they're
you
not-
want to make sure you test so that it's in their urine so that you know they're not trading it or selling it.
Dr. Hyman, do you have anything to add about treatment?
I agree with everything Dr. Kolodny said, although you should count the people who drop out as failures unless they
No, I
re-enroll,
would.
right? And the second point I would make, and this is sort of the incidental consequence of once you start testing people, you suddenly created a gold rush for urine testing. So there's a huge amount of money that's spent on urine testing as part of the treatment.
By the stock, huh? Well, again, that's pretty much my questions, so I'll just go starting from my left to right. Is there kind of one overall suggestion you'd have in terms of change in law or something we should do as a nation to try and solve this problem? Mr. Adelson.
Thanks, Senator. I think incumbent on us first is just to recognize that Medicaid has a large role as a funder of opioids, and so we need to recognize that and understand that we have to do something about it. Admit we're part of the problem, so to speak, in the Medicaid program. Slow down the Medicaid rush. It's increasing the supply. There's no question about it. Even if you go back before expansion, Medicaid enrollment doubled from 2000 to 2013. So that's an issue. So I think we need to slow that down. I would target benefits. I think if somebody's in need of substance abuse treatment, they're low income, everybody in this room, everybody around us wants that person to have substance abuse treatment, but it doesn't necessarily have to come with all the other potential side effects of having that Medicaid card and the free access it provides to other things like opioids.
So put some kind of controls around the benefit. Mr. Schock.
Thanks, Senator. From a very broad perspective, we need to obviously diminish the gap between the impoverished and the middle class. We do that, in my opinion, by creating jobs, incentivizing businesses to grow. When we have people that are going to work in the morning, their likelihood of walking through the courthouse doors as a defendant reduces drastically, especially when we are talking about drug abuse. From a more narrow perspective, as we've echoed here today, I believe that regulating the prescriptions that are being written by our medical community would go a long way in curbing the issues that we're seeing and discussing today. Thank you.
Mr. Tyndall.
I'm going to brag on Tennessee just a little bit, Mr. Chairman. Our controlled substance monitoring database requires every drug, every narcotic that's dispensed, it has to be entered into our controlled substance monitoring database no later than the following business day. So if that's true, and it also requires our physicians to check that CSMD prior to prescribing a narcotic. So if that's true, the doctor should see that this person has already received that narcotic within 24 or 48 hours, and they should not, I would hope, be prescribing the same or similar medication for that patient.
Do you know, relative to other states, are you that much further advanced in terms of that type of monitoring? Is it comparable, or?
I'm not sure, but I think we're much more progressive and aggressive in monitoring and trying to identify people who are committing TennCare fraud,
Okay.
Mr. Chairman.
Dr. Hyman.
I changed the incentives for physicians to prescribe opioids to Medicare and Medicaid beneficiaries as profligately as they do.
Okay, you have to describe that more.
Well, you
More
can,
specifically, what are the incentives right now, and what's different between the incentives as they prescribe to Medicaid, Medicare versus private insurance?
so the incentives for, as I said, Medicare and Medicaid are both sort of passive payers of bills, and so nobody's going to look too closely at your prescribing practices unless, you know, many, many years later somebody happens to be paying attention. So, you know, when you couple that with the reality that the way you bring a clinical encounter to a close is by filling out a prescription and handing it to the patient, what you want is a system that doesn't pay providers to continue that way of doing things, right? So you can use either carrots or sticks to do so, and I'd be happy to talk about how you would design that.
So it kind of goes back, you've got to target the benefits, you have to control them, you have to just make it more difficult for doctors to write prescriptions for Medicaid, Medicare versus private insurance. There's more controls in private insurance, is what you're telling me.
There's, because of the limited networks and the sort of for-profit nature of the insurer, there's going to be a tighter feedback loop in private sector than you'll see in the public programs.
Okay, Dr. Kolodny.
To bring our opioid addiction epidemic under control and ultimately to an end, I think that, well, first off, you have to frame it the right way. And if you understand that it's an addiction epidemic, an epidemic of people with the disease of opioid addiction, what we need to do about it is very similar to what you would do for any disease outbreak, any disease epidemic. It's similar to what you would do for an Ebola outbreak, a measles outbreak, an HIV epidemic. What we have to do really are two things. We have to prevent more people from becoming opioid addicted. We have to see that the people who are opioid addicted have access to effective treatment. To prevent more people from becoming opioid addicted, more than anything else, what you're hearing today and what we know is that we're going to need much more cautious prescribing. We are still, even though prescribing is trending in the right direction, we are still massively over prescribing. Until prescribing becomes more cautious, we're going to keep creating new cases of addiction. For the millions that are addicted, they really need access to effective treatment. And when I say effective treatment, I'm not really talking about detox or rehab, which doesn't work well for most people who are opioid addicted. I'm talking about long-term outpatient treatment. And as you've pointed out, Medicaid is not a silver bullet. I believe to really have the right system available where someone in every county in the United States can walk into a treatment center and be treated that same day, regardless of their ability to pay for that treatment, to really get there, I think requires an investment in the billions. I would estimate $6 billion a year to start to build out these systems, and a commitment from Congress for 10 years of about $60 billion to get where we need to be. And when you consider what this problem is costing us, both the human cost and the economic cost, I think that investment is very worthwhile.
It'll be interesting to see how much we actually spend on opioids and how much money we might save by spending them on Suboxone or something like that. So, again, thank you all. Really did, I enjoyed the hearing. I learned an awful lot, and that's because you folks did a great job. So I appreciate your time, your testimony, and your answers to our question. The hearing record will remain open for 15 days until February 1st at 5 p.m. for the submission of statements and questions for the record. This hearing is adjourned.